Welcome everybody. Thanks for joining us. It's a nice small group tonight, so I think we can be very informal. I think we could, if there's, Katie, I think you want some questions at the end, but if there's three things, feel free to do that. But hopefully, we can make this really interactive for all of it. So I think if you can go to the next slide, we can introduce ourselves, and then we'll kind of go around and each of us make comments. So I'm Tom Flagg, I'm a medical oncologist. I've been in Colorado because I came as a fellow in 2003, and it seemed like a good place. And it's been fun to watch all the development of the cancer center and really see us develop into a destination. I think when I came here, it probably wasn't true. I'm not saying anything to do with that, but it's really been fun to see it develop and really be a place where people come to receive their care. So Liz, I'll pass it off to you to introduce.
Hi, good evening. It's nice to see everybody tonight. I'm Liz Kessler. I'm one of the medical oncologists in the Urologic Oncology Clinic, working with Dr. Flagg, Kim, Maroney, and multiple other colleagues. And I'm a Colorado native and have done most of my cancer care training here in Colorado, trained on the East Coast for medical school, and really in training was struck by the unique patient population that we take care of in the urologic oncology clinic, and really wanted to make an impact, especially in prostate cancer care, and was lucky enough to join the team. So we're happy to talk with you tonight.
Simon and Paul, do you want to go next?
Hi, I'm Simon Kim. I'm an associate professor in neurology. Was previously in Cleveland and been here for about 2 years. I'm a Chicago native. I'm really fortunate and lucky to work with Dr. Maroney, Dr. Flagg, and Dr. Kessler. We really have a great group.
I'm Paul Maroney. I co-direct the Urologic Oncology Clinic with Liz. And as far as why I'm here, I did my residency out here and then went to Indianapolis. And I was sort of chatting with some of the other fellows that were there at the time, and Edmonton, Canada is sort of in the same time zone as Denver. There was another fellow from there. And we were sort of remarking how people in Indiana seem so mean. And, basically moving one time zone east somehow changed people's personalities. Well, there was another fellow from New York there who was saying everybody seems so nice. And so, I think we're in one of the best places to work in, not just in the United States, but I think in the world. I have a great team of people around me, and I'm really proud of that.
Well, Liz, I'll make a couple of comments. I think we can just pass it around between the four of us. The four of us have worked together for years, and many years in some cases. And it's kind of a theme of the multidisciplinary. Over time, we've developed some really strong relationships. And I think about patients, research, other things we do. Again, it's funny. Every time we do a talk like this to patients, we do all of our academic talks and so forth. We always think a little bit about what message do I want to sort of convey to a patient group or to a community group or a group that's really not our academic teaching medical students. A lot has changed in prostate cancer in 15 years. So if I think of myself, last 15 years, my time in Colorado, and really focused on prostate cancer, a lot has changed. I'm a medical oncologist, so I use drugs to try to treat cancer. Doctors Kim and Maroney utilize surgery and so forth. So in the realm of medical oncology, the therapies we have for the more advanced cancers has changed dramatically. When I was a fellow in training, we didn't really have any drugs that prolonged someone's life that had advanced prostate cancer. Now, I'm not saying that we've solved everything but we've made real progress there. We have a variety of drugs that add meaningful amounts of life to people. And frankly, the drugs oftentimes improve the quality of care. We've gone from a setting in oncology in general, so we think about oncology, the field in the last 15 years, to where we are now, to a more personalized approach. We'll regularly check genetics for patients. So rather than saying we treat prostate cancer patients with XYZ, we will do a little bit of that. Maybe the first line of therapy is similar, but then after that, at some point, we'll check a patient's genetic profile. And then based on that, we may say, well, we don't usually use this therapy because it doesn't work unless you have this specific molecular finding. And it goes from being a general approach, a population-based approach, to being really a genetic, individualistic kind of approach, a personalized approach to care. So again, at a high level, I think those are some of the things that I've seen change in the last 15 years. And although, again, there's a long way we have to go in cancer care, prostate cancer care, you start to see immunotherapy, personalized medicine, and I think, my good friend and colleague Paul's going to talk about other things that are doing technology that's sort of moving us forward. So Dr. Maroney, I'll hand things over to you to make some comments.
Yeah, thanks, Tom. So prostate cancer is a big part of my practice, and our audience may or may not know that this is a pretty slow-moving cancer. When we see people, and men still die from this, of course, but generally they're treated for years, if not decades, before we see this. And given this, what we see are, while there are men that die, there are also men that have prostate cancer that really never suffer from symptoms of metastasis or spread. But those men may still end up getting treated, which can have non-trivial side effects for those men. And so this leads us to this trade-off when a guy gets diagnosed is okay, well, I'm afraid, I want to be around for a long time, but I also want to be as whole as possible for as long as I possibly can be. And it brings in some opportunities here for what can we do to try to minimize some of these side effects. And there's some newer options for these patients potentially that we have, and we're just starting to flesh some of this out. The hospital now has the combination of using an MRI, which is fantastic at looking at the prostate for cancer, but also to blend that with newer types of PET scans, which is something that very few places have the opportunity to do. So what a PET scan does is it'll show us more precisely where the cancer is in the prostate. Basically think of this as being a magnet for cancer, is that we can really see where those areas are. And if we are better able to detect those, maybe we can get away with treating smaller areas of the prostate. So this still respects the idea that these are cancers that are meaningful. But also, given we are treating less of the prostate, maybe men would have less side effects from some of these therapies. So we're excited about this. We're optimistic we'll be able to have access to some of these PET scans very soon, but then we need to develop this technology to really make sure that we're figuring out who are the best patients to use this in. Does this actually work? Maybe there's other opportunities that we can use these new types of MRIs and PET scans in. And that needs a certain amount of organization and resources to help get that done. So I'm excited to see where this is going over the course of the next several years in our program. Is how do we help men live longer, but also help men live fuller when they're suffering from prostate cancer.
Should we advance to the next slide?
Yeah. I can talk a little bit about, the future of prostate cancer in a way. So as Dr. Schulich already has shared with us, the cancer statistics are really important. And as we see, prostate cancer really is the most common cancer to affect men. So 1 in 8 men might be diagnosed with prostate cancer. We know that having just advancing age may be one of the most common risk factors to have a diagnosis of prostate cancer. So it's a very common cancer, and yet the treatment is becoming complex. So common doesn't always mean simple, and this complexity in treatment is a good thing. It means that we're learning more about the tumor. We're also learning more about the treatments we have and the effects that they might have on our patients, as well as the tumor. And really within our team, and I think within the future of the cancer care, you'll see that these multidisciplinary teams are working together. So as was mentioned in the beginning of the program, these are teams where clinicians can get together. So in our own group, each week we'll review the pathology, the radiology, we'll talk through an approach, because oftentimes prostate cancer is best treated when multiple approaches are incorporated. So one drug, one therapeutic approach may not be sufficient. We'll do a better job if we combine those. So we use this multidisciplinary team approach in both our clinical planning, as well as I think in our research planning. So oftentimes we as a team are saying, this is a problem we're seeing, this is a question we have, how can we put our heads together as clinical experts and research experts in prostate cancer and see where we can really make an impact to help forward the care for our patients. So we're working to define the standard of for future care of prostate cancer with this disease-specific expertise, but also taking that clinical expertise of these really sometimes complex or unique cases, or even the standard cases where we're seeing the same pattern over and over, and saying, where can we do better? Where can we work together better? You know, what are the ways to collaborate as a multidisciplinary team to really not only improve the outcomes for our patients, but also to see, you know, what outcomes matter to patients. If the cancer is treated better, what side effects do we leave folks with? And are those important to our patients? Do we need to do a better job from that perspective? So it really is putting together the expertise in these disciplines from both a treatment plan as well as a research plan or a research question. Slide.
I wonder if Dr. Kim wants to make any comments on that general, the last slide of this slide.
Well, it's really nice seeing everybody. You know, I've been in practice in several sort of leading academic centers, and I really do believe the team we have here is fantastic. We really provide excellent care that's top notch, and I would respectfully suggest, you know, really one of the best in the region, if not in the nation. And I think, you know, philanthropy is just really, really important for advancing patient care. Dare I say that I would say that philanthropy is really the foundation, really, to develop novel diagnostic treatment strategies that really can be a paradigm shift. And it's really crucial as we consider philanthropy that it is an integral part in advancing patient care. And so it gives us a lot of flexibility and opportunity to pursue novel treatment strategies that can be sometimes out of the box, but yet very critical. Here's a list of some of the studies we've done. Dr. Maroney is leading a fantastic study looking at grapeseed extract to reduce the risk of relapsed prostate cancer. Dr. Kessler is looking at high dose testosterone and its effects in improving advanced prostate cancer. I've been looking at artificial intelligence to see if we can develop ways of diagnosing prostate cancer potentially without a biopsy and maybe better risk stratifying those patients. As Dr. Maroney and Dr. Kessler and Dr. Flake have discussed, it's really about individualizing a treatment strategy for a man who's diagnosed with prostate cancer. And Dr. Flake is, you know, really dedicated in developing new therapies for metastatic prostate cancer in the lab. And I've had, you know, really the very fortunate to work with all three of them. So philanthropy is just a really crucial part of advancing care, and we're very grateful for it.